Welcome to AETCM, the Emergency Medicine channel. Today we have an orthopedic case discussion and we have Dr. Naomi and Dr. John C. from Department of Orthopedics, Amartha Institute of Medical Science, and we'll go ahead with the case discussion.
Today I'll be presenting a case of 80-year-old male who presented to our ER with complaints of fever since last 10 days and swelling in the left knee. On 10-second assessment, patient was conscious, oriented and was obeying commands. On airway assessment, airway was patent, there was no secretion, gurgling, pooling of saliva. On breathing, patient had a respiratory rate of 20 per minute with a saturation of 97% at room air. There were adequate chest excursions and air entry was bilaterally equal with normal vesicular breath sounds. On circulation, patient had a BP of 130/70 mmHg with a pulse rate of 105 per minute. At this time, we had put 2 large IV bore cannulas. On disability, patient had a GCS of 15 out of 15, pupils were equal and reactive to light, and patient had a pain score of 8/10 in the left knee. At this point of time, after ruling out that there is no allergy to injection paracetamol, we had given injection paracetamol 1 gram IV stat. On exposure, patient had a temperature of 100.7 degree and GRBS was 134 milligram per deciliter. Coming to the adjuncts to the primary survey, since patient was having fever and left knee swelling, we had taken a CBC CRP which showed total count of 14,300, HB 11.6 and a CRP of 188. We had also taken a VBG which showed pH of 7.38 with PCO2 38 and bicarbonate 20. Patient also had a lactate of 3. We had reassessed the pain score of the patient, and after injection PCM, pain has reduced to 5/8, and also the temperature was rechecked and temperature was coming down.
So what were your DDs at that point of time?
At that point of time, patient was giving a fever history which was persisting for the last 10 days associated with a swelling in the left knee, and she was also complaining of severe pain in the left knee. So we were suspecting a septic arthritis or a cellulitis of the left knee. Then any infectious pathologies, patient was complaining of dysuria and increased frequency of micturition. So we were also suspecting UTI for the patient.
Yeah, so what are, other than cellulitis and septic arthritis, what else can you suspect?
In case of persisting fever, we can suspect TB arthritis can be kept as a DD.
Yeah. TB arthritis, I think, is much more chronic.
Then gout, acute onset of pain.
Acute on chronic onset of gout, that
gout
is one.
Can be then any trauma related.
Yeah, I think you should suspect cellulitis, one, gout, yes, septic arthritis, yes, and even DVT also, I think you should suspect, yeah.
Coming to the sample history, 80-year-old male who's a known case of diabetes, hypertension, CAD and dyslipidemia, osteoarthritis of left knee, presented to our ER with complaints of fever which was persisting since last 10 days. Patient also had complaints of dysuria and increased frequency of micturition, following which patient was evaluated at an outside hospital where URE was done and which showed numerous pus cells. So initially patient was treated for UTI and then patient was discharged from the outside hospital. Following, patient developed swelling and pain over the left knee which was lasting since 5 days, and also fever was persisting. So patient got readmitted in the outside hospital, from where the from knee fluid aspiration was done, and then it was sent for culture. Reports were awaiting. Since the fever and pain was not subsiding, they had come to our hospital. There is no history of any trauma to the left knee.
So after this, what is the provisional diagnosis?
We were suspecting infection of the left knee, patient already a known case of osteoarthritis, so we were suspecting to be septic arthritis of the knee.
This patient had a history of UTI along with Following that UTA, this septic arthritis has happened. So, what might be the etiology?
It can be a hematogenous spread of the infection can be there.
Okay.
Usually septic arthritis gets through mainly three mechanisms. Either it can be due to the hematogenous spread, or it can be direct infection in case of intra-articular injections or direct penetrating trauma injuries. Otherwise it can be spread from the adjacent skin or subcutaneous infections.
Okay. So, this patient had a recent history of UTA. So, what are the most common organisms which will cause septic arthritis?
Staph aureus is the most commonly known organism for causing
Which
septic
might be
arthritis.
secondary to a trauma or
Trauma.
hematogenous, because of some local infection. This patient had with the previous history of UTA. What will you suspect?
Gram-negative organisms can also cause since patients having UTI.
And also gonococcal, sexually
Gonococcal,
transmitted
sexually.
also should be suspected. Okay.
Coming to the allergic history, there is no allergic history. Coming to the medical history, patient was on insulin and glimepiride for diabetics. On general examination, patient was conscious and oriented. There was no pallor, icterus, cyanosis, lymphadenopathy. On local examination of the left knee, on inspection, there was a swelling on the left knee of about 4 into 5 centimeter, and erythema was present. On palpation, there was warmth present, and patient was having severe tenderness. At this time, we had done a patellar tap, which was found to be positive in the patient. Movements of flexion was restricted due to severe pain. Other systems, respiratory system and CV system was within normal limit.
Was the patient able to walk?
No, severe pain was there.
So you have to actually, from the orthopedic point of view, while presenting examination, it has to start with the attitude of the limb.
Okay.
So in case of septic arthritis, where the knee would be inflamed, so the position of the limb will be in a flex state and slightly externally rotated. So as to accommodate this excess amount of synovial fluid in the joint, that would be the easy position the patient would take, flexed with external rotate. So that would be the first line that you have to say when you start the saying the examination. Patient is lying with the knee, the left knee flexed and slightly externally rotated.
That's the position of maximum comfort for the patient. That's why he would lie down in that.
Yeah, so that's starting with the attitude, then inspection. So inspection, what are the points that you look for when you are suspecting a septic knee?
Usually patient will be having a collection, so there will be a swelling, enlargement of the joint.
Yeah,
and
so
then
you have to say diffuse swelling of the knee.
Yeah, very unlikely it will be a 4 into 6. Or you might have just noticed it like that.
It wouldn't be a localized
It
swelling.
would be more of a diffuse swelling with there would have been a suprapatellar swelling also. A horseshoe shaped swelling is what we usually see.
Yeah, horseshoe shaped. So, but ideally you can say a diffuse swelling. Okay, what we normally call a septic knee is an angry joint. So it will be an angry looking joint. So you have to describe all those points. One is the swelling. Second, what would be the point?
there will be erythema will be present in the swelling.
Yeah, redness. Okay. So that is for the inspection. And then you have to look for any scar sinuses or scars or any discharging sinuses. Yeah.
That will be usually in chronic cases. In acute case for 10-day history, unlikely. The scars, sinuses and all are discharging.
Okay. So next, after we look, what is the second one that will come?
Next, coming to the palpation,
Yeah.
the patient was having severe tenderness on palpation.
Palpation always starts with local warmth.
Warmth also was present.
Yeah. So you have to always palpate.
Should say local warmth present and where the tenderness was.
Yeah. So where do you palpate for tenderness in a knee joint? What are the landmarks?
Over the patella, we usually palpate over the both lateral, medial and lateral aspect of the patella.
Yeah. Mainly we have to check the joint line. From the tibial tuberosity, we'll go supromedially and supralaterally. We'll palpate and we'll check for the joint line. We'll check for the joint line tenderness. And apart from that, you will, like you said, patella, you have to check on either side of the patella facet. All those places we do check. Then
Even the condyles.
Yeah.
Then you have to check for the synovial hypertrophy also in some cases. So, but in case of septic arthritis, there will be localized tenderness. Like patient will not allow us to touch. So that would be the, how clinically the patient would be presenting to us. Yeah, and so local warmth, tenderness. Then what else?
Then patellar tap we had elicited in the patient, so it became to be as positive.
Yeah. So how did you elicit the patellar tap?
We keep the try to make the patient to lie in supine position and then extend the knee. We try to keep the knee in extended position, and then from the thigh we push the fluid. We try to push the fluid from the thigh to the knee and then fix it. And with the other hand, we palpate on the patella. So if there we can see the patella floating if there is a huge collection.
Yeah, we can feel the patella is going and tapping against the femoral condyle and coming back. So that's the patellar
You
tap.
said this patient has osteoarthritis. In osteoarthritis, one thing we do find, if it is a severe deformity, is patient will have FFD, fixed flexion deformity. Can you check for a patellar tap?
No.
So if there is a fixed flexion deformity, you will not be able to complete. You need to completely extend the knee up to 0 degrees or whatever. Then only you can check for the patellar tap.
Yeah. So we finish tenderness and then patellar tap. Then next, look, feel, and
Then restriction like movements we have to check for the
yeah.
patient.
So you have to say.
Do check for enduration also. Enduration is also another important finding seen in infective cases, mainly in osteomyelitis, not much in this thing,
Septic
arthritis. But
arthritis.
yeah, enduration is also another important thing.
Yeah. So movements, it would be.
It was restricted due to the severe pain.
Yeah. Okay. So it's painfully restricted movements.
Apart from the knee, you do check for the leg also. You have to, because we should not focus on septic arthritis alone. Now we have a differential diagnosis of DVT and things like that. So do check for the calf muscle tenderness and things like that.
Also the other joints.
Yeah,
has
and
to be
other
checked.
joints. Other joints is a mandatory thing. You have to check all the other adjacent joints.
Joint above and below, hip, ankle, even spine has to be checked. Okay. Yeah. So movements, measurement. Then something called measurements. Yeah.
Measurements. Yeah.
Yeah. Okay. Next.
Then from ER we had taken a USG of the left knee to see about the collection, and then there was a collection fluid with free floating internal echoes in the left knee in the suprapatellar recess. About 25 cc in volume collection was there in USG. And then we have also taken an X-ray to rule out any osteomyelitis in the patient. Then we had given an orthopedic consultation for the patient, and following that orthopedic consultation, they have come and aspirated the synovial fluid and sent the synovial fluid for the studies.
Right. So how do we aspirate a knee joint?
It should be done in sterile condition. The area should be cleaned with sterling and this, and then with the needle gauge, 18 size needle gauge, we aspirate the fluid, and then the fluid is sent for the different studies, like it can be sent for culture, gram stain, FB, and then smearing can be done.
Yeah. What Dr. Naomi meant was from which.
What's a landmark
There's
for
the landmark you
for
place the needle. Sterile conditions tests and all is there, but suppose if orthopedician is not there and you have to immediately perform an aspiration. Aspiration is something I think even emergency medicine doctors can do. So how do you position the limb? Where do you put the needle?
Yeah. Okay.
Position is, again, you can put the knee in up to 20 degrees of flexion or in extension, and we place the needle supralaterally of the patella, and we direct it into the knee joint and we aspirate. Sometimes immediately we may not get, so we have to direct it slightly that side and this side, and
Basically, we have to go underneath the patella.
underneath the patella.
In the patellofemoral joint to aspirate the fluid. So it's in the supralateral aspect of the patella. Okay.
And then we had started the patient on empirical antibiotics, and then patient was admitted under general medicine department. patient's synovial fluid study came to be as positive for Staph aureus.
That is
And-
in the synovial fluid
Gram
culture.
stain, you mean?
Culture.
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 Okay.
Culture came to be positive for Staph aureus, and the counts were showing more than 50,000 with a neutrophil predominance.
What was there in the synovial fluid? In gross examination, what was there?
It was mostly clear fluid only got, and viscosity was not so thick but light viscosity, less viscous fluid was there.
Suppose it was hemorrhagic, what do you suspect?
Trauma we can suspect if it is hemorrhagic.
So you wouldn't feel it is pus?
No.
Okay.
Other than trauma,
Any other conditions where we get
hemorrhage, coagulopathy, any tumors.
hemophilia? So normally, what's the color of the synovial fluid? Or
It'll
what are
be
the characteristics?
It will be a clear fluid,
Straw colored.
straw color.
It'll be greenish yellow, kind of yellow colored straw fluid.
So, and normally, what is the count?
Less than 200 cells it will be normally.
Total count. Okay.
Total count. If it is more than 20,000, it gives a suspicion, and if it is more than 50,000, it indicates for septic arthritis.
Okay. So when do we say it's an inflammatory, and when do we say it's an infective?
When the counts are more than 50,000, then it mostly indicates of infective pathology. Between 20,000 to 50,000, we can suspect an inflammatory condition also.
Right.
Yes.
Then what are the tests do we look for in synovial fluid analysis? What are the tests? You said
We
total count.
TCDC we look, then we can send for culture, then we can look for gene expert can be done, acid fast can be looked, then fungal smearing also can be done.
What about glucose?
You have to check for additional glucose, protein, and crystals.
Crystals.
We are checking for, we have a DD of crystal arthropathy also. So we have to check for crystals also.
Crystals was negative in this patient.
Yeah, one more DD was there, which even I missed. We have to keep bursitis also as a DD.
Pre-patellar bursitis. That can also present with pain and decrease in the movements.
And following in this patient, we had done an arthroscopic washout was done for the patient.
Just before the treatment, so what do you think? So finally your diagnosis is probably septic arthritis. So what are your findings which are supporting your diagnosis?
The risk factors mainly patient is an elderly patient, one cause. Then a previous history of osteoarthritis of the joint.
I don't think osteoarthritis as such is a
predisposing factor.
very much predisposing factor for septic arthritis. Even young patients are getting septic arthritis. So osteoarthritis as such alone, I don't think so is a major risk factor.
Then a previous UTI infection.
That is
Definitely.
That is definitely.
These were the main risk factors, and also patient is a known case of diabetes for last 30
definitely,
years. These were the risk factors in the patient.
Fine. So that is a history.
Yeah.
Then
From the history point, agree.
And on patient's presentation, patient was having fever since last 10 days, and then patient is
So
also
fever is there. I think his tachycardia, he was tachycardic.
Yes. On arrival also patient was febrile, and then on examination part patient was having swelling was there, patient was having tenderness, warmth was present.
okay.
Yeah, from warmth was present, then
Painfully restricted movements.
he was unable to walk, movements were restricted.
Yeah, and then finally the
And
investigation
then
which
investigation
proved
in USG also there was a collection, and also culture came to be positive for the Staph aureus.
that. Okay.
Yeah, so do you think it is secondary to UTI or we don't know? Because patient has UTI also.
Yeah, mostly, but we can put it as a secondary
Secondary
to
to
UTI. Okay. Yeah. So now what do we do?
After aspiration, we had started the patient on empirical antibiotic.
Do you think an MRI is required?
MRI can be done. MRI is not mandatory for all patients.
Yeah. Septic arthritis is basically a clinical diagnosis. clinically, when we are suspecting septic arthritis, first thing we have to do is aspirate and send for the count and culture, and then accordingly manage it. Okay.
Yeah.
Yeah.
You can go ahead with the treatment.
Patient was started on injection vancomycin 30 milligrams per kg on divided doses, 2 doses per day. Patient was started, and then
I think the treatment was arthroscopy washout.
washout.
So I believe when we do, we can take the cultures during the aspiration. I mean, you can send for culture, but I think during the arthroscopic washout also, it is good to take a biopsy from the biopsy and tissue for culture from the synovium along with the washout. So you have a deep tissue or whatever, you can have another definitive diagnosis.
What do you mean by an arthroscopic washout? I mean, leave arthroscopic. What do you mean by washout of the joint?
Under vision, we drain out all the fluid collection.
Yeah, basically we are cleaning the joint with saline. So we have to push saline and then clean deeply. That's what we meant by washout.
We are trying to reduce the bacterial load as much as possible.
Okay. Yeah, let's continue.
Patient was given antibiotics, and then finally we had done an arthroscopic washout for the patient, following which the inflammatory markers came down, and then patient was started to mobilize, and then patient was discharged.
Again, in the bloods, we have to look for elevated WBC count, ESR, CRP.
Patient was having a total count of 14,600 and an elevated CRP which was showing about 183.
Yeah. What about post surgery?
Post this, the inflammatory markers has come down.
Yeah. We need to make sure that there is a decreasing trend.
Yeah, okay. Post surgery, it would have gone up. Maybe post op day 1, it would be higher. But then we have to follow. I mean, we have to look for
On
the
serial
decreasing
monitoring, it was coming down.
Yeah. Okay. Then, so now, if it's the scenario is happening in a child, how would the child present? Which is the most common septic arthritis seen? Which joint is affected mostly?
Mostly knee joint is affected.
Then
wrist can be affected, ankle
In a
joints can
child,
be.
actually, the hip joint is more affected.
Basically, first is the knee. I'm not talking about the in pediatric age group. First is the knee joint, hip, then shoulder, ankle. So that's how the decreasing trend is. Okay. Yeah. So in child, mostly, just imagine this child is presenting with a hip pain. So how will the child present as? I mean, and we are suspecting septic arthritis of the hip. So how will the child be presenting to us?
A child can present with limping gait due to the severe pain.
Yeah. They won't, unable to weight bear. That would be the first thing. So there's something called Coker's criteria to look for septic arthritis. That is a criteria that is used in children to look for septic arthritis. So what is the Coker's criteria? One, what you said, unable to bear weight. That is the first one. Then there are 3 other blood markers that we look.
One will be ESR more than 40, WBC more than 14,000, and one more is there, CRP.
Yeah, CRP will also be elevated. Okay. So this is what you have to know in pediatrics, Coker's criteria.
Again, you
And
have to look at
temperature.
the
Basically, it's
temperature.
unable to bear weight. Temperature more than 38.5, and ESR is elevated. I mean, CRP will be elevated, and total count more than 14,000.
Again, child may not be walking, so you have to check the attitude of the limb. So in case of a hip septic arthritis, the hip, the attitude for hip is, it will be again in flexion, it will be in abduction and external rotation. In the knee, it is usually just external rotation and flexion. That is the position of maximum comfort or fluid accumulation. Hip, it is flexion, abduction, and external rotation. One important DD is transient synovitis of hip or synovitis of hip. Again, the position is pretty much the same, but the blood markers may not be elevated like this.
And it's all clinical diagnosis. We have to constantly monitor the child. Child will be having it's a toxic looking child, and crying obviously. So that's all we have to do. Okay, then what else do we have? In case of a prosthetic joint.
Yeah, prosthetic joint infections. See, elderly patients when they come, they will have to see if they have undergone any replacement surgeries or whatever. So that time, all these scar marks and any previous history of surgeries should be asked. If you see a midline scar, you should suspect that the patient has undergone total knee or in the knee total knee replacement, and you'll have to assess accordingly because the treatment differs. We may go for something called, we usually do arthrotomy in case of if the patient has undergone TKR. We usually do arthrotomy, not arthroscopic washout we do. And you should check how long when the surgery was done. Suppose it is within few weeks or months, we may go for something called, what I'm trying to say is a scenario where the patient has undergone TKR and has come back with a periprosthetic joint infection or prosthetic joint infection. So you do go for, you attempt a procedure called DAIR, DAIR, which is debridement, antibiotics, and implant retention. So you're trying to basically retain the implant, and we just debride all the synovial tissue, and we give the patient antibiotics, and we retain the implant. We may go for something called a insert change. That is one thing that we do. That is because we want to go posterior. The posterior aspect of the knee has to be debrided and all that. That's why we go for an insert change. And suppose if it is a chronic infection, we can go for either a one-stage revision or a two-stage revision. Two-stage revision is the gold standard treatment for periprosthetic joint infection. So in that, what we are doing is we take out everything because we don't want to keep some. We have to go for a repeat surgery basically. So we want to take out all the implants. We want to clean the entire joint. We want to debride it. So, and we either give, now there are custom-made spacers available for the knee joint. So the patient can walk and they can flex, extend and all that. Sometimes we do give some, handmade antibiotic, cement spacers we give. But now there are custom-made spacers also. So after giving antibiotics and for usually it is given for around 6 weeks. I think it's given 6 weeks IV and 6 weeks oral. Yeah. So after around 2 to 3 months only we go for a second procedure or the definitive procedure after confirming that there is no remaining infective pathology as such.
By looking the blood markers.
Yeah, by blood markers. If you want to go again for confirmatory thing, you will have to go for either a PET scan or something like that. That will give you a functional imaging also. Because we are giving a new joint.
So we got to know what is the orthopedic point of view. From the ER, we will be mainly doing the pain management and the antibiotics. So here we got it as a gram-positive cocci or staphylococcus. Okay. So what are the other organisms which can infect?
In gram-positive, mostly staph and strep can cause. Gram-negative organism Pseudomonas also can cause for the infection. Then if the patient is sexually active, gonococcal infection also should be suspected.
And in immunocompromised individuals, there can be tuberculosis, fungal infections, and rest of things can happen. So suppose it is coming as gram-negative bacilli, can be secondary to an abdominal infection or a urinary tract infection, either a hematogenous spread. So what will you do if we are getting as gram-negative bacilli? What antibiotic will you
Then
plan?
we have to start third generation cephalosporins. Ceftriaxone 2 gram OD can be started, or ceftazidime 2 gram TID can be started for the patient.
So before going into that, we need to know whether the patient is having any, whether the patient is immunocompromised or any IV drug abuse is there. If that is not there, you can go for that. If that is there,
if that is there, then we have to look for whether there is any neutropenia, severe sepsis, all. And if those features are not there, then we can give a single coverage antibiotic, that is ceftazidime can be given.
Along with an anti-pseudomonal coverage.
Agent.
Okay.
If the risk factors are there, then two antibiotic coverage for the pseudomonal should be given. So there we can give either a macrolide, a beta-lactam with an aminoglycoside, or this can be given.
Okay. Fine. Anything else from your side? Okay. Thank you.